Although advances in the realm of artificial intelligence in medicine definitely remain weighted toward algorithm development and algorithm validation, both clearly essential in this realm, the real ultimate goal is for us to be able to implement AI algorithms clinically and really get to the point where they have a positive impact on patient care. My name is Theodora Potretzke. I'm a radiologist at the Mayo Clinic in Rochester. And our article forthcoming in Proceedings is Clinical Implementation of an Artificial Intelligence Algorithm for Magnetic Resonance-Derived Measurement of Total Kidney Volume. What we have investigated in our paper is that with coordinated interdisciplinary effort, can we implement an artificial intelligence algorithm in real life, in a real clinical practice? And can it perform as expected? Can it perform as it did in the controlled pre-implementation environment? This should be the goal that we seek. I want to take a step back and give a little clinical background on this topic. Here at our institution, we have a world-class and very high-volume center for polycystic kidney disease care. Autosomal dominant polycystic kidney disease is the most common genetic cause of chronic kidney disease. We know it causes relentless kidney cyst growth, kidney enlargement, and irreversible renal parenchymal destruction. The disease is slow and progressive. In radiology and imaging, we really do play an essential role in the care of PKD patients, both in the disease diagnosis as well as disease prognosis. What we have learned through prior research is that the total kidney volume in a 80 PKD patient is a very reliable biomarker to predict renal functional decline. Actually, now it's an FDA-approved prognostic biomarker for the risk of eGFR decline in patients with 80 PKD. It's an absolute must-know for nephrologists, both for patient prognostication and patient counseling, and also to determine eligibility for novel disease-modifying drug therapy. So in radiology, we're close partners with our nephrologists and other members of the PKD team. We obtain imaging on these patients and look to calculate the total kidney volume, which is essential again in patient care. But this is very arduous and time-consuming to do manually, which is the way it was done for many years. We are fortunate that in our practice, we have an AI algorithm that was developed here at our institution and was subsequently validated through a large data set that itself can measure total kidney volume through images acquired in MRI. It's potentially so useful for getting reliable data quickly to our referring colleagues and our patients that we really wanted to get this algorithm implemented in the clinical practice in real life. Patients come from a far distance, they're here for their visit, they get their imaging, and with the AI algorithm, we can get their total kidney volume calculated at the time of the imaging encounter so that when they go on to clinic, they have that information right away. So what we did in our study was looked back at the clinical implementation of this algorithm in our imaging department. It took a lot of interdisciplinary effort to make sure that it was implemented in an effective way. We had 170 cases that we reviewed for this paper of the AI algorithm running in a clinical encounter under an IRB. And what we did was with each of those cases, had image analyst and a radiologist the opportunity to review the organ segmentation that the algorithm produced and edit it if they saw that it could be further optimized. We then went ahead and analyzed that data to look at measurements of similarity and dissimilarity between the algorithm output on its own and those cases that were reworked. And we found high rates of similarity between that and very low rates of a significant volume difference in our calculations. We had very good agreement in the algorithm output itself versus any edited algorithm output. And in fact, the mean volume difference was just negative 3.3%, which is actually less than inter-observer variability when done manually. And we found that there was a non-inferiority in the AI algorithm output versus that which was manually edited. So in the results of our study, looking at the 170 cases that we reviewed, when given the opportunity to rework the output of our AI algorithm, about 49% of the time, the radiology technologist or the radiologist flagged a case for rework. However, those cases which were reworked showed very, very low mean volume difference when the human adjustments were made. Not only does that show that the algorithm itself performed well, but that those cases which were accepted without rework were accepted at a very high standard. The performance of the algorithm showed very high mean similarity measures, very low dissimilarity measures, and overall there was very good agreement between the AI algorithm output alone versus those outputs which were edited by a human observer. And again, the output was determined to be non-inferior. In conclusion, we discovered that the performance of an artificial intelligence algorithm in a large and complex clinical practice could be preserved if we paid careful attention to the validation of that algorithm during development, and if we took a conscientious approach to implementation and education of stakeholders during the process. So future work will include, implementations of workflows where radiologists and other disciplines can further evaluate future algorithms in clinical practice. In our case, we will be including liver segmentation, as this is an important element of the ADPKD disease phenotype. I think the results of our investigation should encourage clinicians to really champion implementation efforts in their own practices if there's potential for an algorithm to improve practice and positively impact patient care. I appreciate the interest in our paper and invite you to read it in Mayo Clinic Proceedings, and hopefully it can add some insight into how we can merge the potential of AI algorithms in medicine to the realities of complex clinical practice. And thank you.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.